Welcome, all participants, to the International AIDS Society Educational Fund webinar entitled STIs, Global Trends and Prevention Interventions. I have the pleasure of moderating today's session with Dr. Rodney Perkins. I am the chief of the Craig-Dalsimer Division of Adolescent Medicine, professor of Pediatrics and Medicine at the Children's Hospital of Philadelphia and University of Pennsylvania School of Medicine. I also am an IAS Governing Council member. The aim of our webinar is to really provide updates on the global STI trends with a particular focus around Doxy post-exposure prophylaxis. We'll spend some time overviewing the evidence, as well as focusing particularly on certain populations around the world, women, as well as rollouts from San Francisco, data from Brazil, as well as a focus on vaccines for gonorrhea. I'd like to welcome today's speakers. As shown here, Angelica Espinosa, who is the Program Director of Health and Environmental Surveillance, Secretariat, Ministry of Health, Brazil. Chase Cannon, an assistant professor of infectious diseases at the University of Washington and medical director for the Public Health Seattle and King County Sexual Health Clinic. Felix Mogaga, clinical research scientist at the Kenya Medical Research Institute, Research Care and Training Program in Kisumu, Kenya. Sinead Delaney Moretwe, professor of global health and infectious diseases at the University of Witwatersrand, Johannesburg, and director research WITS RHI, and Stephanie Cohen, director of HIV/STI prevention section at the San Francisco Department of Health. Thank you for being here, and thank you also to our donors, ViiV Healthcare and Gilead Sciences. I'm now pleased to introduce my co-moderator for today, Rodney Perkins, research scientist of DoxyPEP study at the University of Washington, who will be introducing a few housekeeping rules.
Thanks, Renata, and thanks everyone for being here. Please note that due to the number of attendees, all participants are currently muted. We've planned time after the presentations for a Q&A session. Please send any questions that you may have for our speakers focusing on today's topics in the Q&A box at any time. If your question is for a specific speaker, please indicate their name when typing your question. You will notice that there is a thumbs up symbol when someone will ask a question in the Q&A box. If you have a similar question or find this question important, please click on the thumbs up sign to help us prioritize the questions. In case you have any, issues with Zoom, you can find additional guidance provided in the chat box. Please also send us any technical questions you may have there as well. In the chat box, feel free to also let us know which country you are connecting, what time it is there for you. We love seeing interactions in the chat box.
Our first speaker is Angelica Espinosa, Program Director of Health and Environmental Surveillance, Secretariat, Ministry of Health, Brazil. Angelica will be presenting the current global state of STI trends, and the floor is yours.
Yes, thank you, Dr. Sanders. I hope you can see my screen. It's a pleasure to be here and can talk about STIs trends. I'm very happy to see that STIs is included now in the agenda. And when we talk about STIs, we are talking about several infections that they share the same mode of transmission, but they have different etiologies. And the main importance now, it has been a very ancient infection, syphilis. It's very ancient, but it's very frequent nowadays. And you can see that even in the general media, it has been a lot of attention about syphilis, because now it's also common in high-income countries. And we have the problem with STIs in general, but also with syphilis, that we have a lot of asymptomatic cases among women. And it's not the general media, but even WHO has been monitoring STIs. And over the recent years, many countries have reported increasing rates of STIs, such as chlamydia, gonorrhea, syphilis, and trichomoniasis. And this trend has been observed across various age groups and demographics. And it is important because WHO last estimates think that we have about more than 1 million new cases of bacterial infections nowadays. And we are talking about bacterial infections, but if we include the viral ones as HPV, that is very frequent and can be associated with cervical cancer, the problem is even bigger. And the estimates shows that the problem is among men and women and different country income categories, and it's present in all WHO world regions. Then we need to be attentive about this problem and see how can we control it. And how to control the STIs. It's not easy to approach about the sexual infections. But the Global Health Observatory data from WHO has been monitoring it, and we can see that we need to be attentive, even in populations that we think is from low risk, as pregnant women. We need to be attentive if they have access to syphilis tests or other STI tests, and when they are positive, if they are having access to treatment. And they are in higher risk of congenital syphilis. That is the main problem that we need to be attentive, because even in high-income countries, we have seen cases of congenital syphilis is increasing. I am from Brazil, and here we have a lot of problems with congenital syphilis, and syphilis is a very big challenge for us. But also, we cannot forget about the key populations. That's why it's very important to be controlling together with HIV, because we have a higher prevalence among key population. Here we can see men who have sex with men and sexual workers. And what we can do and how is it higher risk? Young people, particularly those aged 15 to 24, continue to be at a higher risk of acquiring any STIs. And we know that several factors such as lack of comprehensive sexual education, inconsistent condom use, and multiple sexual partners contribute for this increased vulnerability. Then it's a challenge to approach young people and STIs. But we have also another concern, because there is growing the emergence of drug resistance strain of STIs, particularly gonorrhea. And the AMR is making some common treatments less effective, posing challenges for health providers. And we need to be attentive with that, because gonorrhea is the most important, but it's not the only one. Now, we also have cases, the MR for chlamydia trachomatis and mycoplasma genitalium. Then we still don't have in Brazil and in so many countries diagnosis available for mycoplasma, and we already know that many cases are resistant. And how we can do that? We need to improve the access to testing and treatment, because disparities in access to STI testing and treatment still persist, with vulnerable communities often facing great barriers. And this population are the ones that should be tested and treated. And the limited access to healthcare, stigma, and discrimination can hinder individuals from seeking tests and treatment services, even in low middle-income countries. And we cannot forget about the impact of COVID pandemic on STI trends, because while some regions experienced the temporary declines in STI diagnosis due to lockdown measures and reduced social interactions, other countries saw increases as healthcare resources were diverted away from STI service. Then we still need to learn the real impact of COVID pandemic on STI trends. And as an IAS event, we cannot overlook the association with HIV/AIDS. Although HIV not solely is classified as an STI, as it remains a significant global health concern, and the effort to control HIV and AIDS continue with progress in some regions of the WHO due to increased access to antiretroviral therapy and the prevention programs. But we did not see yet the impact on sexual transmitted infections, because however challenges such as stigma, discrimination, and access to health care still persist. Despite all the advancement in HIV prevention efforts, these improvements have not translated into comparative progress in preventing STIs. Then it will be very important to be discussing other lectures here that is talking about vaccines, PrEP and PEP for STIs, because we need to put STI closer to HIV prevention strategies. And what about prevention efforts we are talking about? Because prevention remains a cornerstone of addressing STI, with efforts focused on promoting safe sexual practice, increasing access to testing and treatment, and decreasing the stigma about sexual health. Comprehensive sexual education, access to condoms, and regular screening are very important components to prevention strategies. And here we need to focus on HIV and STI as a block. And in summary, I would like to say that it is very important to keep going about the prevention and education strategies to prevent STI and start to change the trends. Here in Brazil, we have been using a lot of tools as a national guidelines, online courses, webinars, some material for the health professionals. We start publishing also the national protocol in papers, because the intention is to include STI in the agenda. Thank you.
Thank you, Dr. Espinosa, for that great presentation. Our next presenter is Dr. Chase Cannon. Dr. Cannon is an assistant professor of infectious disease at the University of Washington and medical director for the Public Health and Seattle-King County Sexual Health Clinic. Dr. Cannon will be presenting on the current state of DoxyPEP. The floor is yours, Dr. Cannon.
Thank you very much. Hello, and thank you for the invitation to join today. So I'll briefly review the current state of DoxyPEP and frame some of the issues that that my fellow speakers will further explore later in this webinar. So DoxyPEP stands for doxycycline post-exposure prophylaxis, and this is the strategy of taking 200 milligrams of doxycycline by mouth within 24 to 72 hours after condomless sex to prevent bacterial STIs, which you just heard about. So primarily this is an intervention for chlamydia and syphilis, but also gonorrhea in some contexts. This is a fairly new intervention that is sex positive and can be controlled by the user to reduce their own risk for bacterial STIs. We know that doxycycline is a common antibiotic that we've used for years for treatment and prevention of many conditions. It's cheap medication, it's safe to use, and it's generally well tolerated. We do have evidence also to suggest that interest in DoxyPEP has been high for several years, even before the public release of results from the randomized trials. However, there do remain several ongoing debates about which population should be eligible for DoxyPEP, several uncertainties of longer-term risks that it may have on resistance and potentially the health of users, and whether this intervention should be used or promoted for gonorrhea prevention, given the variable rates of gonorrhea resistance globally. So this is a table of the empiric evidence that we have for DoxyPEP in 2024. I bring your attention to the right side of the table that shows you the efficacy estimates, both for relative risk and absolute risk, stemming primarily from 3 randomized trials that were looking specifically at doxycycline post-exposure prophylaxis. I'm not including here pre-exposure prophylaxis, which is a different intervention. So primarily these studies were done in people assigned male sex at birth, so cisgender men who have sex with men, and then in one case in the DoxyPEP study in Seattle included transgender women. Primarily these were people taking HIV PrEP, and then in the DoxyPEP study also people living with HIV. The top conclusions from these are that efficacy is what you can see there, anywhere from 47 to 84% for chlamydia and for syphilis. For gonorrhea, there was also an effect in the last 2 studies, DoxyPEP and DoxyVac. I will not be discussing the trial that was done in cisgender women, as you will hear about this later in the webinar. We also have emerging data to address several concerns about DoxyPEP. So first, with respect to safety, adverse events in the randomized control trials were rarely severe, and there were few discontinuations related to those. A systematic review of over 10,000 patients who used doxycycline for weeks to years found that gastrointestinal effects such as nausea, stomach upset, loose stools, and then rash were the most common. However, these side effects were self-limited, and not all adverse events in the review were attributed to doxycycline. And then antimicrobial resistance, as you just heard, is a major concern for both STI and non-STI pathogens. Both the United States and the French DoxyPEP trials found variable levels of tetracycline resistance in culture isolates of Neisseria gonorrhoeae and between group analyses, suggesting that DoxyPEP may be less protective against strains that have existing resistance. And then in the US DoxyPEP trial, a small absolute increase in tetracycline resistant Staph aureus was seen, and then depicted in the figure to the right, this represents a larger analysis of rectal swabs from participants showing there was an increase in the number of expressed antimicrobial resistance genes specific to tetracyclines within gut bacteria, but there was no significant change in the bacterial diversity over time or between study groups. We have not really seen tetracycline resistance in Chlamydia trachomatis, thankfully, or in Treponema pallidum, the agent for chlamydia and syphilis respectively, but there is concern that this could develop and spread for other bacteria such as Mycoplasma genitalium, as you just heard, and then commensals like oral Neisseria species or Streptococcus pneumoniae. Although we do have some emerging data to address these concerns, there still remain several unknowns about DoxyPEP, and these include longer-term risks for antimicrobial resistance, how DoxyPEP might impact our ability to diagnose syphilis, and particularly how this might impact symptoms of complicated syphilis or neurosyphilis, whether being on intermittent doxycycline will cause those symptoms to be more subtle and thus not able to be detected more readily. And also how long we might expect DoxyPEP to have any effect for gonorrhea prevention. We hope to continue learning about more of these issues over time. There are groups that are studying these, but unfortunately, there may not be any sort of comprehensive or definitive answers to these studies and these questions for many years to come. So while we wait for these longitudinal data, we need to decide how or if we will proceed with promoting DoxyPEP right now. And so many local and regional health organizations and ministries of health, even for entire countries, are considering these the evidence and weighing the risks for their communities. And so some of the things to consider in the balance on the pro side include the things that you see here on the left. So patient demand and interest seems to be very high. Again, that was even prior to some of the studies being released. We just discussed some of the clinical efficacy and safety, which seems to be good. We will hear a little bit later about some early evidence on population level effectiveness. And then we do have some data as well from the US DoxyPEP trial that it does seem that DoxyPEP is associated with enhanced sexual pleasure and also peace of mind for people who are using that intervention. And then perhaps as a trade-off, we can see that people who are using DoxyPEP may not have as many gonorrhea infections, so there could be a reduction in overall ceftriaxone use. Then on the con side, we have to consider that there is still considerable provider discomfort, lack of guidelines, especially in the United States, and concern for AMR that could be induced, lack of adequate surveillance systems as well to pick up on AMR before it spreads, and then a lack of consensus on who is the best target population for DoxyPEP. And then you'll hear about some implementation challenges as well that make this something difficult to implement. So in summary, we've got evidence from multiple trials conducted in people assigned male sex at birth that support DoxyPEP as part of a comprehensive package of STI prevention tools, primarily for chlamydia and syphilis, and probably less likely so for gonorrhea. We know this is cheap, safe, well-tolerated intervention that can be controlled by the user. However, there are several ongoing debates on how to weigh the apparent benefits with the known potential and some theoretical risks. So I think we stand at a crossroads here, and we should all sort of decide for ourselves in our communities, where do we go from here? And we will hear more about this to come. Thank you, and I will turn it back to the moderators.
Thank you, Chase, for that wonderful presentation. Our next speaker is Felix Muguga. Felix is a clinical research scientist at the Kenya Medical Research Institute Research Care and Training Program in Kisumu, Kenya. And he'll be speaking to us on DoxyPEP and cisgender women, the data that we have, as well as the gaps. Turn it over to you, Felix.
Right, thank you for the kind introduction. Yeah, so I'm going to take you through this trial that was done among cisgender women in Kenya, then look at some of the implications from this study and the next step. So generally, women who are eligible for HIV PrEP have high incidence of bacterial STIs, and in some places, the burden is comparable to MSM. And STIs in women are often asymptomatic compared to men, and if untreated, can result in serious complications, especially in the uterus. DoxyPEP have been mentioned is been reducing incident STIs among cisgender men and transgender women with high STI burden, but this was not the case in a similar trial among cisgender women with high STI burden in Kenya. The Kenyan trial randomized participants in a ratio of 1:1 to either DoxyPEP within 72 hours of condom-less sex or standard of care, which comprised of quarterly STI testing and treatment. The study participants were 18 to 30-year-old cisgender women with an active HIV PrEP prescription. Follow-up for this study was done every 3 months and comprised STI testing, treatment, and prevention counseling. The participants in this study also received a weekly SMA survey with coded questions on frequency of sex and on doxycycline use. This design, that is recruiting people who are already on PrEP and then doing the weekly SMA survey, maximize the adherence by recruiting women taking a daily pill and also from the SMA survey. The primary endpoint for this study was any new chlamydia, gonorrhea, or syphilis infection. So the baseline characteristics were similar across the two randomization groups, with a median age of 24 years, use of PEP for a median time of 7 months prior to being enrolled, and high prevalence of STIs at enrollment at 18%, and primarily driven by chlamydia. There was a very low rate of syphilis, which is consistent with other studies in the area. This study had a very high retention rate of 97%, and 81% of weekly SMS surveys were completed. There were 80 pregnancies during the study, 44 pregnancies among the DoxyPEP group, and doxycycline was withheld during pregnancy. And this hold accounted for about 10% of the quarterly follow-up time among the DoxyPEP group, and the other holds due to other reasons accounted for around 5% of the follow-up time. Overall, the STI incidence was very high at around 27 per 100 person years. There were 109 incident STI infections over the course of the study. 85 of these were chlamydia infections, 31 were gonorrhea infections, 8 were co-infections of gonorrhea and chlamydia, and there was only 1 syphilis infection. So 50 of the 109 infections were among those assigned DoxyPEP, and 59 were among those in the standard of care. There was no statistically significant difference between these two groups, including after answering for the doxycycline hold during pregnancy. And also, we conducted subgroup analysis, including by age, contraceptive use, transactional sex, and STIs detected at baseline. And there still was no statistically significant difference between these two groups. Self-reported adherence was moderately high. Use of doxycycline following sexual exposure or full coverage was recorded for 77% of last sex acts that were reported during follow-up. In 73% of the quarterly timeline follow-up calendar surveys, where participants looked back 14 days when they had sex, whether they used a condom or whether they used doxycycline. There was full coverage in more than 80% of the time. In text message surveys, 64% of participants reported full coverage in more than 80% of the time. And of all the weekly text survey, 78% were consistent with full coverage. We also collected blood samples at all quarterly follow-up visits for testing of doxycycline presence, and only 29% of the 200 samples tested had doxycycline detected. So there are several possible explanations for the lack of STI prevention with doxycycline PEP among cisgender women in this trial. One interpretation may be that a 200 milligram dose of doxycycline taken within 72 hours of condomless sex does not prevent STIs in endocervical tissue. The types and frequency of exposure may also be different between cisgender women in the DPEP Kenya trial and participants in other studies. Another possible explanation for the null results is antimicrobial resistance. However, as mentioned by the previous speaker, there are no documented cases of resistant chlamydia globally. The high prevalence of tetracycline-resistant gonorrhea likely explains the null results, as 100% of the samples we collected here were resistant for tetracycline. And self-reported doxycycline PEP adherence was moderately high, using a full coverage definition that included all correct use of DoxyPEP. However, only 29% of hair samples tested had doxycycline detected. Evaluating adherence to event-driven medications like DoxyPEP, which is recommended after instances of condomless sex, is challenging. Sexual activity is inherently difficult to quantify beyond self-report. So consequently, the lack of detection of doxycycline does not imply non-adherence, and also detection of doxycycline does not imply adherence or correct use of doxycycline PEP. It is also possible that some women may have only used DoxyPEP after condomless sex with non-primary partner. It therefore means that doxycycline for STI prevention might still work for women. Additional trials of doxycycline PEP are needed. Similar studies among different populations should focus not only on effectiveness, but also on acceptability and self-efficacy. There is also need for better understanding of the barriers and facilitators to adherence so that we can support use. So lastly, the next steps include a study that's planned here in Kisumu again, weekly doxycycline directly observed therapy. So it's a follow-up pilot study in response to the participant feedback on the barriers to use of DoxyPEP. And we'll be providing a small cohort of around 50 clients with weekly observed therapy of doxycycline. So we will also use this cohort to compare incident rates with those in the standard of care group in the recently completed DPEP Kenya study. Then there's another study being planned in the US for doxycycline effectiveness among people assigned female sex at birth, and we hope this may shed more light on whether this intervention is effective among women. Thank you very much. Happy to take any questions.
Thank you, Dr. Nakata, for that nice presentation. All right, our next presenter is Dr. Sinead Delaney-Maltway. And Dr. Maltway is a professor of global health and infectious disease at the University of Witwatersrand, Johannesburg, and director of the research WITS and RHI. Dr. Maltway will be presenting on vaccines for gonorrhea. Dr. Maltway, the floor is yours.
Sorry, I'm getting my slides into presenter mode. Hopefully you can see that in presenter mode.
Yes, thank you, Sinead.
Okay, so thanks very much to the IAS for inviting me to present on vaccines for gonorrhea. There are an estimated, sorry, I'm having trouble advancing. There we go. There are an estimated 83 million new cases of gonorrhea annually, and we are way off track to achieve the WHO goals of reducing gonorrhea incidence by 90% by 2030. The majority or the highest prevalence and incidence of gonorrhea is in the WHO Afro region, and men have a higher prevalence of gonorrhea than women. Many of gonorrhea infections are unrecognized or asymptomatic, and this leads to a lack of diagnosis and treatment. There are significant consequences of untreated gonorrhea, particularly in individuals assigned female at birth. And these include infection in the upper genital tract leading to pelvic inflammatory disease and infertility, as well as adverse pregnancy outcomes and neonatal complications, including preterm birth and low birth weight, which are associated with increased morbidity and mortality, particularly in low and middle income countries. Gonorrhea has also been associated with an increased risk of HIV acquisition and transmission. And these complications mean a significant burden or cost to the health system, particularly in resource-constrained settings, as well as have an impact in terms of stigma and reduced quality of life for patients. But the real reason that gonorrhea has probably leapfrogged to the top 10 priority list of pathogens has to do with the emergence of antimicrobial resistance. Global surveys in 2018 showed that about a third of isolates were resistant to ceftriaxone, and about 50% of isolates were resistant to cefixime. And what we have seen are multi-drug resistant infections that are associated with clinical treatment failures coming out of Japan, but that have been exported internationally. So we face the real prospect of untreatable gonorrhea without further intervention. Vaccines are considered a potential strategy for managing antimicrobial resistance, because you can prevent infection, reduce antibiotic use, and therefore reduce resistance. But there are a number of challenges to the development of vaccines for gonorrhea, and this is partly because of the wide genetic diversity as well as strain variation within gonorrhea, and this is and the fact that we don't have a model of human immunity. This has really meant that for the last 100 years, we've not had significant progress in the development of vaccines until this study, which is a retrospective case control study from New Zealand, which was conducted after a meningitis B outbreak, where people vaccinated with an outer membrane vesicle-based vaccine, an outer membrane vesicle vaccine had lower rates of gonorrhea. Vaccine effectiveness was estimated to be about 31%. It waned after a few years, and effectiveness was lower in people who were co-infected with chlamydia. What these results have really been recapitulated in a number of observational studies, all using outer membrane vesicle vaccines, where the vaccine efficacy has been observed to be between 30 and 60%. Now, observational evidence is helpful, but what has been reassuring that there is a potential effect of meningitis B vaccine for gonorrhea prevention comes from this molecular and preclinical data. Part of the reason is that gonorrhea and meningitis come from the same species family and have about 80 to 90% sequence homology. A number of the vaccine antigens are present in both pathogens. And what we have observed is that sera from meningitis B vaccinated humans cross-react with gonorrhea. But more importantly, preclinical data from 4C-MenB immunized mice have shown that antibodies from 4C-MenB have functional activity against gonorrhea, accelerate the clearance of gonorrhea, and reduce the bacterial load with a fourfold increase in bactericidal activity. So you may be thinking that a vaccine with modest efficacy of 30 to 60% may be too low, but a range of mathematical modeling studies have suggested that even with modest efficacy, we could expect to see population impact. And this is a modeling study assessing vaccination of all men who have sex with men attending UK sexual health clinics. And what they saw is that even with a vaccine that was 45% effective, but the duration of protection of 4 years could achieve the WHO goals of reducing gonorrhea incidence by 90%. And what this has led to, in fact, is that the advisory committee in the UK for vaccination has actually recommended vaccination with 4C-MenB for men who have sex with men who have a history of STIs. This is in the absence of trial data. So we have had one trial reported. This was the DoxyVac trial that was conducted in 544 men who have sex with men in France. And although the curves separate and the vaccine group appears to have a lower incidence of gonorrhea, this was not statistically significant. However, there are a number of other trials that are in progress, predominantly in men who have sex with men in the US, Thailand, and Australia. And these are expected to have results in 2025. In recognition of the fact that individuals assigned female at birth may experience a higher burden of the complications of gonorrhea, that there are different modes of transmission, and they may also have different responses to vaccines, the Gates Foundation has funded a study that will be conducted in 1,100 women, including 200 people living with HIV in South Africa, that will be led by colleagues at the University of Washington and ourselves at Wits University in Johannesburg. And results from that trial are expected in 2026. So there are a number of other gonorrhea vaccine candidates that are in development. The most advanced is probably the GSK gonorrhea-specific OMV vaccine. That trial is in phase 2 and has completed enrollment, and results are expected as well in 2025. There are also a number of other vaccines early in development that use a range of platforms, but the pipeline is relatively full. And WHO and partners at the NIH have really done an enormous amount of work to stimulate the vaccine field and have produced a preferred product characteristics document, as well as a full value of vaccine profile for Neisseria gonorrhea vaccines. And it's well worth a read if you are interested. So in summary, we have an urgent unmet need for prevention options for gonorrhea, particularly in low and middle income countries. We have exciting observational evidence as well as preclinical data that suggests that meningitis B vaccine could prevent gonorrhea. Modeling suggests that even a vaccine with low efficacy could have a population impact, and there are trials in progress to evaluate vaccines for the prevention of gonorrhea, with results expected in 2025 and 2026. So really, I think the challenge for us is to anticipate these potential trial results and to generate data on acceptability and demand, as well as potential implementation strategies in countries with overlapping gonorrhea and meningitis epidemics. Thank you very much.
Thank you, Sinead. That was wonderful. Our next speaker is Stephanie Cohen, who is the director of HIV STI prevention section at the San Francisco Department of Public Health, and assistant professor at the University of California, San Francisco, in the Division of HIV, Infectious Disease, and Global Medicine. Stephanie will be speaking to us about translating evidence into action from a public health standpoint using population data from San Francisco. Thank you, Stephanie. The floor is yours.
Thank you so much for the introduction. Good morning from San Francisco, and thanks for the opportunity to present after such a wonderful lineup of speakers today. As you have heard this morning, the global burden of sexually transmitted infections is extremely high. And San Francisco, as a small city in the United States, has particularly high rates of bacterial STIs. Here on the left, you see gonorrhea rates from 2017 to 2021. San Francisco is the dashed orange line at the top of the figure. You can see we have higher rates compared with New York City, LA, California, and the United States as a whole. On the right, you see 2021 syphilis rates, and again, San Francisco has particularly high rates represented here in the orange bars on the left. This figure shows STI rates in San Francisco against a background of annual HIV diagnoses illustrated with the gray bars. The positive news in this figure is that in San Francisco, we have seen declining numbers of new HIV diagnoses between 2012 and 2022. And at the same time, over this time period, we have had quite high increases in STIs, from a 76% increase in chlamydia from 2014 to 2019, a 72% increase in gonorrhea, and a 45% increase in early syphilis. So with this high burden of sexually transmitted infections and emerging data about the efficacy of doxycycline post-exposure prophylaxis, we as a jurisdiction felt like it was critical that we roll out this new tool as quickly as we could to our community. And as the results of the DoxyPEP and DoxyVax studies became available, we started discussing how could we implement DoxyPEP in San Francisco. And today I'm going to focus primarily on sharing our thoughts on eligibility criteria, and how we've been monitoring uptake and population level impact. The first question that comes up as we start talking about DoxyPEP implementation is, to whom should we offer this tool? The randomized controlled trials, DoxyPEP and DoxyVac, both focused on men who have sex with men and trans women who had had a bacterial STI in the past year. Some have argued for more restrictive use of DoxyPEP. This strategy would maximize the benefit-risk ratio, minimize excess antibiotic use, but more restrictive criteria may make it more complex to identify candidates and could potentially reduce the reach and impact of the intervention. Others have argued for broader use to meet the high patient demand for new strategies for STI prevention, to embrace an anti-stigma approach, and to lead to a greater reduction in the absolute number of STIs prevented. However, broader use also means more use of antibiotics. And as you've heard already today, antibiotic stewardship and antimicrobial resistance are two of the main concerns with broad use of DoxyPEP. So we weighed these issues and brought together community, scientists, public health practitioners, and other stakeholders, and came together, and in October 2022 became the first jurisdiction in the United States to release guidelines for DoxyPEP. As early adopters, we felt that it was important to align primarily with the RCT criteria. And in our guidelines, we recommend DoxyPEP to those who would have qualified for the randomized controlled trials that showed DoxyPEP efficacy, specifically cis men and trans women who had had a bacterial STI in the past year and who had had condomless anal or oral sex with one or more cis male or trans female partners. We also prioritize people with a history of syphilis in these populations for DoxyPEP. However, we did feel it was important to go a bit broader than the RCTs and also include a provision that providers can offer DoxyPEP using shared decision-making to a broader group, including those who may not have been diagnosed with a bacterial STI in the past year, but do have multiple sex partners. At this time in San Francisco, we do not have a broad recommendation for DoxyPEP in cis women, given the results of the Kenya DPEP study. But we do advise that providers could consider DoxyPEP for cis women on a case-by-case basis. And we eagerly await results of the additional studies on DoxyPEP in cis women, which will be forthcoming. DoxyPEP is not a standalone intervention. It should be offered as part of a comprehensive package of sexual health services that includes multiple interventions, including primary prevention, vaccines, HIV pre and post-exposure prophylaxis, and linkage and retention and HIV care, secondary prevention, addressing social determinants of health, and advocating for public health policies. After the release of the DoxyPEP guidelines in October 2022, we began systematically offering DoxyPEP at our municipal sexually transmitted infection clinic, San Francisco City Clinic. This is a nationally recognized center of excellence in sexual health services where we offer integrated HIV, STI, and reproductive health care grounded in a syndemic approach. This is a low barrier clinic where we offer drop-in as well as appointments, and we serve a diverse population, and approximately 50% of our patients are LGBTQ. We found that our MSM and trans female patients on HIV PrEP were very interested in using DoxyPEP. Between November 2022 and May 2023, 74% of our PrEP, MSM and trans female PrEP patients who had had a bacterial STI in the prior year chose to initiate DoxyPEP, as did 60% of patients who'd had 2 or more sex partners but no STI history. We found that uptake was associated with having a higher number of sex partners in the prior 3 months. This is a good thing. We want DoxyPEP to reach this population. And it was not associated with any specific demographic factors, including age or race ethnicity. In order to monitor DoxyPEP uptake across our city, we, in partnership with our local HIV Getting to Zero consortium, embarked on a sentinel surveillance effort where we have been working with our municipal STI clinic, San Francisco City Clinic, as well as a CBO-run sexual healthcare clinic and our large HIV safety net clinic in San Francisco. And each of these clinics is reporting by quarter the number of individuals who've started DoxyPEP as well as their demographic characteristics. And we found that between October 2022 and December 2023, almost 4,000 individuals have initiated DoxyPEP in San Francisco. So the next question that everyone has been asking us is, okay, you have rolled out DoxyPEP in San Francisco intentionally. What is happening with citywide STI rates? So we've worked with our epidemiologists to analyze trends in chlamydia, gonorrhea, and syphilis in MSM after the release of the DoxyPEP guidelines. In these figures, which show chlamydia on the left and syphilis on the right, the vertical gray dashed line represents when DoxyPEP guidelines were released. The black line represent monthly case counts. And what you see here on the right of these figures is the blue dashed line is the modeled predicted trend in the absence of a change. And the green dashed line represents the observed trends after the release of guidelines. And as of November 2023, we found that chlamydia cases were 50% lower than modeled forecasts, and syphilis cases were 51% lower than modeled forecasts. We did not see a decline in gonorrhea cases after the release of DoxyPEP guidelines. And in cis women, a population in whom we have not broadly recommended DoxyPEP, chlamydia cases have been increasing in the post period. In conclusion, San Francisco Department of Public Health moved quickly to translate evidence from a research study into services for our community. It took a remarkable citywide collaboration and our very engaged community to facilitate early adoption of this new tool. We do have encouraging early evidence of the potential for a population-level impact of DoxyPEP on chlamydia and syphilis, but at this time, not on gonorrhea. We need longer follow-up and to replicate findings in other jurisdictions. And we certainly need more information about antimicrobial resistance. In the meantime, we advise providers to support their patients in assessing their need for, interest in, and use of DoxyPEP, and recommend that our guidelines for DoxyPEP evolve as evidence emerges, and that they continue to be informed by community input. I want to thank first and foremost our patients and study participants, as well as the many collaborators that have made this work possible. Thank you.
All right, thank you, Dr. Cohen, for that great presentation. It's always good to start to see the data. Data kind of is really exciting to kind of get an idea of how the instrument is actually working. All right, so I just want to remind everyone, we're going to move into our Q&A time now. Again, if you have any questions, please put your questions into the chat box at the bottom of the screen. Again, just make note which presenter you'd like your question to be directed to, just to kind of help us with the flow of this particular conversation. I see there's been a lot of conversation, a lot about AMR in the chat box, a lot about Doxy use in women. I'm going to try to kind of like organize the questions a little bit so we can kind of get a good conversation going here. And I had a question set up. And so I think the first question that kind of came to mind for most people is kind of, what are the real strategies for addressing and reducing stigma and discrimination of lesbian, bisexual women and trans women in communities with the respect of women's human rights, to encourage them for the use of protecting things like condoms, and to be proud for medical services. I assume this wasn't directed to anyone specific, but I'll just open it up to the panels for anyone to kind of want to respond to that particular question.
I can start.
Okay.
Can I start?
Sure.
Yes, I think it was a very good question because we need to improve our health professionals' education, because I don't know if it's everywhere, but in Brazil, we have a lot of problem with that. Stigma and discrimination is making difficult this kind of population, the key population, come to the services. And I think we need to improve the education strategies, not only for the health professionals, but also for them, and to try to have special clinics or even in the primary healthcare clinic, because it's the most common in the majority of our countries. We need to be prepared to receive this population. And I also like the idea of self-tests with online explanation, education, because we need to improve the access skill for them.
Yeah, thank you for that. One thing that did come up in the chat, which I'd love to hear from the other speakers as well, is how to combine use digital technologies, point of care testing, home testing, to really increase that access that you're speaking about, to address the discrimination that exists for marginalized communities, transgender women, for example, LGBTQ plus individuals, and really how do we combine it with DoxyPEP, right? So there's an opportunity, right? Point of care testing, someone could then get the medication at home. So maybe I'll ask both, start with Stephanie. What do you think? What are opportunities?
Yeah, thank you. I think it's an excellent point. And I also just want to echo the first question and the critical importance of addressing stigma and creating stigma-free, low barrier access points for people to receive services. And I think home testing is one way to address that. It's a complicated field. There's a lot of different ways in which we can do this. In the United States, we have a free home testing program supported by the CDC and our National Association of State and AIDS Directors, NASDAD, for men who have sex with men, called Take Me Home, where people can order an STI test kit package to be mailed to their home. And I know that particular program is interested in including information about DoxyPEP in the portal where people go in to order the test. So you find out about the testing options, you order your kit, and at the same time, you're able to receive evidence-based, high quality, sex positive, non-stigmatizing information about prevention tools like HIV PrEP and DoxyPEP. At the same time, at least in the United States, there's a lot of commercial options for home testing, some of which are quite expensive, and we can't really control necessarily the quality of information that people receive when they're purchasing these home kits. I think it's also a space where there's a lot of new technologies in development, and a lot of potential issues with cost being a barrier to access. So I think there's quite a lot of potential there to reach people and to allow people to screen in a more private and confidential manner.
Okay, I think there was a question. I was trying to combine a question a little bit, but I think the question really was around Doxy use in women, looking more specifically at women with regards to pregnancy. Just want to kind of go back to the question to Yeah, so basically just look, and maybe Magaka, you can speak to the concerns around doxycycline use with regards to cis women and the concerns around pregnancy. I think there was another question with regards to breastfeeding that someone else brought up as well. Magaka?
Thank you. So, yeah, there are a number of questions. We started on for pregnancy. It's true that doxycycline generally in many places, the guidelines don't recommend it for use among pregnant and breastfeeding women. But there is more recent questioning of that reasoning, because this was based on evidence from use of tetracyclines. But more recent evidence suggests that doxycycline may not have the same effects as tetracycline, the tetracyclines had. So it's still a gray area, but it's not recommended currently for use among pregnant and breastfeeding women. It's an open discussion. And then there was a question around how. So let me just see what the other question was around how it was provided, how the DoxyPEP was provided. So in this study, 50 doses were provided at enrollment and at follow-up. So these are 100 capsules, and these were provided after STIs. And last week, someone asked me to summarize the results of our findings. What I would say is that in this population, DoxyPEP did not work. However, there was we think that this was driven by low use and probably a definitive RCT to answer the question of whether it is effective among cisgender women. Over.
I think the question also asked about particularly if there were immunological factors that contributed to the differences that we're seeing in the trials that were inclusive of people assigned female sex at birth. And if you could comment on that. And as you're commenting on that, I think that this, has raised multiple questions around populations that have been left out so far in the data that we have, and really acknowledging the gaps in particular populations. Thank you, Angelica, for really bringing in the youth lens, but youth in particular are another population that have been left out of the current clinical trial data that we have. So maybe, Felix, if you could comment on the immunological differences, potential differences, and the data surrounding that. And then anyone else can comment on other populations that have been left out.
Thank you. So the question about differences between men and women, there have been some studies which was published and on pharmacokinetic levels of doxycycline among cisgender men and cisgender women. So looking at doxycycline levels in urethral tissue, cervical tissue, after 1 dose of 200 milligrams of doxycycline. And this suggested that the levels in both cisgender women and cisgender men were sufficient to actually treat gonorrhea. And for prevention, it's possible that lower levels would even be sufficient for prevention. So probably right now, based on the available data, we don't have reason to believe that these weaknesses probably contributed to these results. We have noted in our trial, we had low levels of doxycycline use, and that at the moment that seems to be the most likely factor. Thank you. I'm not sure if I can recall the other question, but I'll answer it if it comes back to me.
All right, the question for Dr. Motley. Dr. Motley, someone asked, why and where do we see long-term secondary protective immunity after gonococcal infection? And can you speak to more structural similarities that might explain the meningococcal vaccine efficacy against gonorrhea?
Yeah, thanks for that question. I think the bottom line is because of the wide antigenic diversity of gonorrhea, there are a number of strains, but also gonorrhea is able to kind of organize itself and present itself differently, which means that the immune system never really kind of is able to kind of mount a sufficient response, and that's why we often see recurrent infections. The reason why we have seen this effect of meningitis B vaccines for prevention of gonorrhea has to do with the fact that the pathogens are very similar. The vaccine that is using something called the outer membrane vesicle, which is clearly sort of common to an antigen that's common to both. There's some additional antigens on the 4C Men-B, which are also common to both pathogens, and that is, we think, stimulating a sufficient immune response, but we don't actually have good data on what that response is and what the correlates of protection are. So that's why these trials are going to be really important for helping us to understand what are sort of surrogates of protection for and really to help us, I think, develop the next generation of vaccines, which might be gonorrhea specific. But really, we don't have a good model of human immunity, and that combined with this wide antigenic variation probably explains why there isn't kind of natural immunity to infection the way there might be for other infections.
Well,
So there was a follow-up question to that, which was about the introduction and uptake of gonococcal vaccines downstream amidst of the relatively higher vaccine hesitancy generally, and to potentially recipients given STI stigma. Are opportunities being explored regarding co-formulated vaccines such as HPV and gonococcal vaccines?
Yeah, it's a really great question, and I think it's one of the reasons why, as we have these trials ongoing, we really should begin to kind of get our heads around the acceptability of vaccines, whether or not they're associated with stigma, what we understand there might be in the way of uptake, but also demand at a country level. So I think there's a real opportunity to develop a better understanding of what sort of future implementation might look like. I referenced the WHO preferred product characteristics document, and one of the things it does very nicely is articulate potential delivery strategies. And one of the challenges with co-formulation with HPV is probably that the target age group is a little bit different. For HPV, you want to vaccinate young people who've not been exposed to HPV, whereas the sort of peak incidence for gonorrhea is likely an older age group. But this idea of co-formulation of vaccines is a live discussion, and certainly there's interest in co-formulation of a sort of chlamydia gonorrhea vaccine. There are pitfalls to the combination vaccines. You essentially get trade-offs between sort of efficacy and potentially immune interference. And so kind of I think what we want is to be able to demonstrate that we can make these STI vaccines work, like for gonorrhea and chlamydia, but certainly there is a lot of interest in combination. My last comment is that, you know, there may actually be an advantage to having a Men-B vaccine that also kind of has protection against gonorrhea, for the precise reason that in many parts of the world, including my own country, South Africa, we can't actually, it's not cost effective for us to introduce Men B vaccination, even though mortality is very high. It's just that incidence is low. But that cost effectiveness ratio may change if we have an indication for gonorrhea, because it's very prevalent. And so this is sort of, and it may also reduce stigma to say you can be vaccinated for meningitis with the sort of benefit of gonorrhea. So these are some of the conversations that have been going on in the background, but certainly there's a need to understand greater acceptability and demand.
Wonderful, thank you for that.
Dr. Cannon, I wanted to turn a question over to you that was put in the chat earlier, really around how we might better optimize the efficacy of DoxyPEP and avoid resistance. Can you speak to any potential combination regimens? I think someone specifically called out Doxy and azithromycin. We know that those are somewhat duplicative and that there's in the same class of medication, but maybe you could speak to, are there ways to maximize and optimize efficacy while avoiding resistance?
Sure, yeah, so I think that is an idea to do combination therapy for prevention. As you mentioned, there is some overlap in terms of the coverage, so I don't necessarily think there's a benefit in using azithro in addition to doxycycline for chlamydia, because we think doxycycline works very well and the efficacy is high for that. For syphilis, I would not rely on azithromycin anymore. I mean, I think for the last 20 years or so, it has not been a reliable antimicrobial agent for syphilis prevention or treatment. And so I think you're just sort of adding potentially excess toxicity in terms of gastrointestinal effects. Specifically, I think with azithromycin, if you add that on top of the doxycycline for not much benefit. Same idea for gonorrhea. I think for Neisseria gonorrhoeae, there is some benefit potentially to using azithromycin, but I think variable rates of resistance we see across the world. And so we can't necessarily rely on that. We would have to do a trial specifically for it, but I don't know that that combination specifically will add too much more benefit.
Are there other combinations that are in the pipeline, just to follow up?
Sure, yeah, and then I guess I forgot to answer the other part of that. I am not aware of any other combination prevention strategies. Maybe others might be. And then things we can do to optimize. So I think there's a couple of questions about people having potentially side effects to doxycycline. So if people do have side effects to the 200 milligrams taken sort of at one time, I have told people that it's reasonable to space out those two pills by a little bit. So you could take, one 8 o'clock and then the other one at 10 o'clock if you want to space it a little bit to not give your system the entire dose. That may be helpful as a way to optimize. And then the other thing is being careful about sort of who we are offering DoxyPEP. So as was discussed about weighing sort of the risks and benefits for each particular person. If someone has only had pharyngeal chlamydia one time in their life, perhaps what they're already doing in their life is sufficient for prevention, and we sort of reinforce that and talk to them about other ways that they can prevent STIs, and maybe DoxyPEP is not for them, that the risk of side effects might be greater than any potential benefit they would have at that present moment, but that could always be reevaluated over time.
Right, Dr. Cohen, I have a question for you. It's kind of two parts because it's coming from two different people. So the first question is, how can the data from San Francisco DoxyPEP rollout inform similar initiatives in Nairobi, Kenya, where there's different demographic profiles and healthcare infrastructure? And then the second question really talks about has the intervention of DoxyPEP freed up capacity in your services overall? Is it helping with rapid access to care, et cetera? Do you provide DoxyPEP by post, online, et cetera, without the needs to attend in person if asymptomatic?
Thank you, Rodney. Great questions. I think the first question, how can our data inform implementation and evaluation in other settings is complex because there's so much diversity across jurisdictions in the epidemiology of STIs, in the landscape of sexual health services and how healthcare is delivered, and what the perceptions and attitudes are towards sexual health in general, right? The degree of stigma. So I think it's hard to have a one size fit all approach. I think that in jurisdictions where there is mandated reporting of positive laboratory STI tests, we're able to track, as we did in San Francisco, trends in STIs and look for changes in trends. And I think that that's work that we hope will be done in many different places so we can better understand if there is in fact an association between rolling out DoxyPEP and reducing STIs at the population level. And I think the other thing I would say about, our experience informing other jurisdictions is that within each jurisdiction, it's so critical to identify the champions of this approach to sexual health, both at the provider level and in the community, and to identify where those key points of access will be. So in San Francisco, it's a relatively small city, and we have some high volume clinics that provide a large proportion of sexual health care. So we were able to partner with those sites early. So those are some reflections I think that could be applicable in other places. To the second question, has the rollout of DoxyPEP freed up capacity? I would say that there is a tangible decline in the number of STIs that we're diagnosing in our PrEP cohort in our clinic. I can tell you that our colleagues at a large health maintenance organization have shared that their inboxes where they receive positive STI tests results have shrunk considerably. So there is, I think, in that sense, a tangible impact for healthcare providers and the work that they're doing. And I hope, of course, that that's true for our patients as well, who are, less frequently having that experience of being told, okay, you're positive, you've got to come back in, you've got to notify your partners. So I think that is certainly what we want to be seeing. And then to the last part of that question, I think, was about online access. We have seen that there are a number of companies and places that are providing HIV PrEP online in the United States. So you can go into various websites and order HIV PrEP and again get sent a kit that you can test at home. I'm not aware yet of any online DoxyPEP providers similar to HIV PrEP. I think that likely would be coming perhaps after the CDC guidelines are released. And generally, I think trying to facilitate like telehealth and express visits for these types of services helps with access for patients.
Excellent, thank you.
I want to just ask a question that was brought up in the chat to both Dr. Cannon and Dr. Espinosa. Dr. Espinosa, you brought up Mycoplasma genitalium as a STI that is quite prevalent. And because we're not routinely testing for Mycoplasma genitalium, I think the question that has come up is really looking at other forms of resistance, particularly in other organisms, and how that might impact treatment in other outcomes. Mycoplasma is a ascending or upper urogenital tract infection. So what is the data around the impact of DoxyPEP on other resistance and other very common STIs? Dr. Espinosa and then Dr. Cannon.
It's a good question, and it's a concern in Brazil. We have been working, and 2 years ago, we start national studies to see how the frequency was, because we know almost nothing about mycoplasma. And for our surprise, we did a study in pregnant women and another one in men with genital urethral discharge. And it was a high prevalence, around 8 to 9%. And now we are working on the data for resistance, and it's amazing because it's preliminary results yet, but we are finding very high rates of resistance, and for an infection that we don't test yet. Then it's very complicated because we are trying to include in the country the screening for chlamydia and gonorrhea, because we were very concerned about the AMR for gonorrhea. And then we are finding now that we have a new problem. We need to know more about mycoplasma and see what it can cause. We don't know yet if we need to monitor for pregnancy, but it's very expensive to put in the public health system the screening for mycoplasma, because everything is new. And we needed to see how to work on PrEP clinics and STI clinics and see how to test when there are chlamydia or urethral discharge that there is resistance to treatment. And then I would like to point out the importance of the AMR monitoring. We need to be attentive for it, even know that we have the DoxyPEP, that I think it will be a very good thing for STI, but we cannot forget about the AMR for gonorrhea. And then now we start to think that maybe it can also the mycoplasma. But I'm telling you about Brazil, that I know the reality, and I don't know if it's the same everywhere. But now in Brazil, as public health policy, we don't screening for mycoplasma. We only did a national study to see if we had, because even that we didn't know if we have mycoplasma, if it was frequent or not frequent. And now we have a new problem because we have mycoplasma and it is very frequent in Brazil. And we need to see how to do.
Yeah, thank you for the question. So I guess I can add as well, I agree that surveillance is a big problem. So we don't know necessarily how much Mycoplasma genitalium is out there. And we're still trying to understand, even if we can detect it, what that means in a person. We know that other Mycoplasma species live in the urogenital tract and don't necessarily always cause a problem. But specifically for Mycoplasma genitalium, I think we're more in tune a little bit with the macrolide resistance, which can directly impact how we craft our therapy plans for people. So I'm not aware of there being any sort of large population-based studies that look at specifically tetracycline resistance, but I think that's always a concern because tetracycline resistance has come up in other mycoplasma species and ureaplasma, for instance, which has been identified in the urogenital tract. So I think it's plausible that it could happen for MGen, but I don't know that we know that particular estimate for sure.
Thank you to you both. Well, I want to circle back to my question earlier. Maybe Stephanie, you can start. Dr. Cohen, sorry, you can start. Just focusing on youth. Youth have the largest proportion in the US of STIs, chlamydia and gonorrhea, than other populations. We've sort of left youth out. We start at 18 years and go up. Most studies are very adult, driven with a higher age, average age of enrollment. So what's needed to really look at this within youth, and how do we move forward in this area?
Thanks for bringing this back up. I think it's a really essential issue in terms of populations that have not yet been really fully included in this conversation and need to be. I think we also saw similar challenges with HIV PrEP, where youth were not included early, although subsequently and over the years we do have, you know, a number of important trials that have been done looking at HIV PrEP in youth that have highlighted some of the different challenges with implementation and some of the strategies that can be used to support adherence to biomedical prevention in youth, which can be harder. So I think first and foremost, we need more data on DoxyPEP in youth, and hopefully both in the implementation science phase of DoxyPEP rollout, we'll be able to include younger people and achieve and learn more about both real world effectiveness and how to support implementation and adherence. I think the second piece of it, though, really comes back to the issue around data for cis women, because when we look at STIs in youth, it's really young women who have the highest rates and who suffer the most morbidity from STIs, and the risk of PID and infertility is particularly high when young women acquire gonorrhea and chlamydia. So I think we both need more data in youth, but again, we also really need more data in cis women.
So Dr. Cannon, there's a couple of questions that have come up, and I'm just going to kind of summarize a little bit. But could you speak to the correlation of taking HIV medication with DoxyPEP, and what are some of the challenges have been for those living with HIV, and getting those that particular population on board with taking DoxyPEP, and what are some of the data have talked about just those who are living with HIV taking DoxyPEP as well?
Yeah, thank you for the question. So the US trial did include people who were living with HIV and were taking antiretroviral medications. And so it is safe to do that. We don't necessarily see drug interactions between doxycycline and many of the antiretroviral medications that people might be taking. The only thing to consider is, depending on the number of medications people are taking, if it's new to them, taking doxycycline on top of that, especially if it's frequent, can lead to potentially more side effects. So again, the gastrointestinal side effects are one of them that come up the most. And there's no issue even with taking HIV post-exposure prophylaxis as well. So people using, say 28 days of antiretroviral medications after an exposure, there shouldn't be any interaction with that. But again, the more medications you're taking, so if you had, for instance, a sexual exposure and you're taking multiple medications for post-exposure prophylaxis, that just sort of adds the potential for side effects and is maybe not the most tolerated, but there's no particular contraindication to using both at the same time.
All right, well, thank you. Thank you, everyone. Thank you to our speakers. This was a very wonderful webinar, really great comments and questions that were asked today, and I think we got some really excellent information. I just wanted to remind everyone that the link to this will be available in the future, and that the link has already been provided. You will automatically receive an evaluation survey to provide feedback around the webinar today. Your feedback is really important as we continue to develop programs, webinars, address topics that are of interest to you. So please, please, please complete the survey, and you can click on it right there, take a picture, and go to the QR code. Thank you again, everyone, for participating in this webinar, which has now come to an end. I'd like to let you know again that the recording will be available, and a transcript will be available as well, with some of the speakers who there was some difficulty with the voice We would like to inform you that there's another IAS Educational Fund that will be coming up on May 30th, which will provide the latest updates on the analytical treatment interruptions in HIV cure research. And if you're interested, please feel free to reach out to the IAS Educational Fund team. The registration webinar will open soon. We wish you a nice morning, afternoon, evening, wherever you are from around the world. Take care.